This year, 2018, marks 30 years since the inception of the recognition of World AIDS Day on December 1st. In these 30 years, 7 Caribbean countries have achieved a major milestone, the elimination of mother-to-child transmission of HIV and syphilis. Only 4 other countries in the world can boast of similar success. The first of a 4-part series about that celebration is up next on CaribNation. On World AIDS Day 2017, representatives of several Caribbean countries were hosted by St. Kitts and Nevis. They celebrated the elimination of mother-to-child transmission of HIV and syphilis by 6 new countries after Cuba, which was first a few years earlier, a major achievement, and CaribNation was there for the celebration. This is the first of a 4-part series in which we talked with several groups of people about the commitment and hard work that led to the success. First, with the team from St. Kitts and Nevis led by Gardenia Gastang Richardson. They had great cooperation between the private and public sector, which built trust in their clientele.
So the National AIDS Program is a national response involving both the St. Kitts Island and the Nevis Islands. So it's a federal response to HIV and AIDS. It involves a multi-sectoral party where we have more than one partners involved. It's not just the Ministry of Health. It includes private sector, civil society, etc. We operate under a number of priority areas, primarily prevention, care, treatment and support, advocacy, research and surveillance, and program management. So under this program, basically, we're responsible for everything as it relates to HIV and AIDS.
Sounds like
it starts with the awareness of the disease and teaching persons about it, to get them to get tested, to move to the next phase if they're positive, to care and to treatment, and all the way down to just managing the data. So it's a comprehensive program that we are responsible for under the national program.
Let me switch to you, Linus, and tell me a little bit about your role as the coordinator of nursing services.
Yes, we deal with persons from the womb to the tomb. So we deal with everyone, yeah. and that involves persons with HIV and testing and screening. But more so as it relates to the elimination in terms of HIV and syphilis, we are under the maternal and child health program, where the pregnant woman and the child would come in and the unborn child comes in. And so we are more on the ground ensuring that persons who access the services at the health centers, and also incorporating those with integrating with those in the private sector, and ensuring that they have the required tests and services that are necessary for them to ensure that they have a healthy outcome in terms of prevention of mother-to-child transmission of HIV and the syphilis. Now, I must add that since we've started, even though the HIV program has come on board many years ago, like 2005, I think, syphilis, which is very much more, that has been from way back, very much so. And so you find that structure has always been in place, both in public and private. So there are protocols, there are guidelines in terms of both public and private, in ensuring that mothers are being tested to ensure to prevent the syphilis transmission during pregnancy. And so now that we have HIV on board, we have we call the Siamese twins. Now we have the 2, and so in terms of dual, ensuring that they have that initial test in the beginning of their access to the service, whether it's private or public, and then just before delivery, another test. And so we have a very unique situation in St. Kitts and Nevis, in where clients actually go from public and private, and they interchange back and forth during the pregnancy. So I think it's a little bit unique as it relates to our services. So we have that integrated and that partnership within the public and the private as it relates to that specific population in terms of our pregnant women. So we really We have that close collaboration, and because St. Kitts and Nevis is small.
I was just going to
Yes.
say that makes it so much easier because you're a small knit group and with a small population. I wanted to know how easy it was to have the people buy into these concepts in terms of all the programs that you put in place, all the strategies you put in place to help eliminate mother-to-child transmission, such as using publicity. I know Live Up was one of the programs to help people get tested and to try to eliminate the stigma, which I think is so difficult in a small society.
Right.
And so I was interested in that uniqueness that you talked about, the partnership, because that makes it so much more successful. To be able to get everybody to buy in.
But one of the things one needs to remember is that one of the things that we have going for us is the public confidence, and this is not just about HIV and AIDS, it's about primary health care, and this goes way back. And so we have that confidence in terms of the services that are offered, and so the antenatal services is just one of them, and so we have that from day one. So you find it's a routine. These are routine services that are being offered. Yes, so it's already been established. We have the support from the ministry level right down to the nurses level. And so you find everyone is committed to ensuring and seeing that we have quality care, and it's about public health. And so we're looking at the public as opposed to that individual client. So we're ensuring that the public get the best quality service that we can offer, it affordable, accessible, and I may quickly add that our services in the public sector is free.
Let's hear about NEVIS, Nadine. NEVIS is a part of the Federation of St. Kitts and Nevis.
Correct.
And we've often heard that NEVIS is sort of the stepchild, that people think that they're left behind or they're just an addition on the side. Tell me a little bit about how difficult it is or has been for you as coordinator to set in place some of the strategies that have been set out.
Well, I will have to disagree with the stepchild statement. I think, of course, we're two separate islands, but we're one federation. Of course, we have different dynamics. However, when it comes to the national HIV/AIDS response, I think we have a very strong relationship, and because of that, we have been able to mirror exactly what's happening in St. Kitts, in NEVIS, and we've been pretty good because we're even smaller.
Yes,
so
of course. Yeah.
The partnership and collaboration with our partners, our private doctors, community health nursing services, which is the mirror image to what Nurse Brown does here, and the mirror image to what Gardenia does in St. Kitts, and our private partners and NGOs, it's easier to tap into that resource. And so we've been able to offer the quality care and services and make sure that persons are tested, persons know the information about HIV and AIDS. We're everywhere. People know us. You're referred to as the AIDS lady when you're seen. So, yes. So they know us. They expect us at the regional testing day, which is one of those things that I think would be a key success in normalizing HIV tests in the open, because we do that in an open parking lot.
Really?
And so it has reduced. Persons look forward to it every year, so we thank the Live Up campaign for that also. So we've been making strides. I think we're in a good place, and because of that, we're able to be certified as eliminated mother-to-child transmission of HIV and syphilis.
In terms of the bigger picture, what do you want to see going forward, and what are the things that you want to put in place, if you haven't already put them in place, to make sure that you harness the confidence that you talked about of the public, but also the enthusiasm that this ceremony, this achievement has engendered, and where do you see it going?
Okay, so I think what's important for us moving forward is the acceptance and the normalizing of HIV and syphilis testing, and just generally of a holistic approach to health. In our system, we do not just approach a person based on a disease. So when you come in to do diabetic care or etc., we ask you about your HIV status, have you had the test, and if you're pregnant, you get a whole variety of tests. So for us, it would be normalizing where every person feels and takes responsibility for their health, and that they would have their annual checks, and if they're pregnant, knowing what is in place and accessing those services. And so for us, while this is a great success, and we want to be able to sustain this, meaning that we want to have less women showing up who are positive, and we want to be able to have less babies infected with HIV. We just want it to be the norm that persons understand treatment is available, care is there, that your baby does not have to be born with either HIV or syphilis or any other illness that we are able to prevent.
Right.
So we just want person to have that attitude when they're coming, that the system is there, that we have put things in place, and to build that confidence that we will take care of you when you come, and you will get a holistic approach to your health.
The tiny island of Montserrat was represented by their Minister of Health, Ms. Delmaud Ryan. She felt that their success was due not only to trust in the system by the patients they served, but also to the fact that their government made adequate provision for funding in their budget instead of depending on outside assistance.
Montserrat is small by measure in comparison to many of the other Caribbean countries in relation to its population size, but it does not take away the fact that we too face some of the very same challenges such as HIV and AIDS in our population. The validation process spanned over several years, well before I became a Minister of Health, and so it required that even before that time, the measures that were in place in terms of record keeping, in terms of the protocols required when treating with persons with HIV and AIDS, that includes how the doctors, the lab, and the nurses all collaborate in this exercise, that this was critical to ensure that there was consistency in record keeping and data collection, especially that most of our records are all paper-based. So it was important to ensure that the information that was collected was sound and that it held integrity in order for us to meet with the objectives of the work plan as laid out for the validation process. My involvement was really to encourage my team when I came on board once I was aware of this exercise happening, and to ensure that all participants were engaged in the process. I've also met with the team on Ireland, met with my own team, met with the team that were doing the validation process, and in giving support and to let them know how important it was for Montserrat. Even though that we've had our challenges, we took the challenge of ensuring that the elimination of transmission of HIV and syphilis was priority for the Ministry of Health. And with that support, it empowered our nursing fraternity, those in the pharmacy, those in the lab, and even the private doctors and those living with HIV and AIDS to be comfortable that the process that we're going through, and even as we deal with the process that is in place for pregnant mothers, where they have their tests done, screening done every trimester. This became part of the routine, and so it became acceptable by persons who were pregnant that this was part of improving their health care should they be found infected with HIV in protecting their newborn.
Montserrat had, as you said, its challenges. Most people only know Montserrat in relation to volcanoes and the damage that you suffered. And so you've had a number of years of recovery. How easy was it to harness the support or the commitment of the population to what you were doing when you consider where they had been and some of the challenges they have had to deal with and overcome? Something like HIV or worrying about medication and going to clinics and that sort of thing. And in a small community, the stigma and shame. How were you able to overcome that, and how difficult was that in that small community?
I think one of the benefits of a small community, especially where persons feel confident or of the fact that their information is not shared all over, this helped to build that confidence with those new patients coming on board or individuals who have to seek services of the clinic. I think what made it easy is because it was, especially for the mother-to-child elimination, it became part of the process. So everybody did it. So it wasn't like you were chosen and I was not chosen. Everybody did it. So they knew that this was part of the package of care that is available to a pregnant woman when dealing with screenings for syphilis, HIV, and the likes that may affect them or their newborn.
Delcora Williams is program manager for the HIV program in Antigua and Barbuda. A midwife by profession, she has an intimate understanding of the obstacles pregnant women face. She has seen the number of babies born HIV positive decline consistently through the collaborative hard work of a large team of practitioners financially supported by a committed government.
Well, in Antigua and Barbuda, syphilis was a reportable disease, and so we were always testing our mothers for syphilis. And so with HIV, our national response started in 1992. And for our PMTCT, that started in 1999, where each pregnant woman was offered a free HIV test.
I see.
And so from 1999, we started our program. One of our obstetricians, Dr. Abbott, he actually went to the Bahamas, and at that time they were given AZT only, and they had a very
advanced, one of the drugs for HIV.
Yes, for HIV. And they had a very advanced program, and so that is the program that he brought back, and we adopted initially, where we were just giving AZT to all women who tested positive for HIV, and then we test the baby at 18 months and see what's happened. Yeah. But then with us getting like our new clinical care coordinator, Dr. Fernandez, she started us on triple therapy, and she also started or initiated option B+, where all our pregnant women who tested positive were started on ARVs and for life.
Oh, the antiretrovirals
for life. And so we started that since 2012. And so our program has moved from like one step to the other, and we continue to improve.
Build on that.
Yes, we've built on it, and we have seen success throughout the years in the fact that initially, yes, we had some mother-to-child transmission, but from 2011 to and we had no transmission. In 2012 we had one, and then in 2013, 14, and 15 we have had no transmission, and then in 2016 we had one.
How big is your team that you work with in terms of putting all the support pieces in place?
Well, I would say maybe about 54 persons. Because we have both our private and public sector involved, our private obstetricians and our public obstetricians involved. We have 24 health centers where we offer antenatal care also, and that is free. As much as possible, our government tries to ensure that any kind of care and treatment in Antigua is as free as possible. And so we have our primary health services where a pregnant woman can access antenatal care. We have midwives that are trained, that will counsel and make sure that that woman know her HIV and syphilis status. If they are positive, they are referred to our high-risk clinic, where we have a next team of persons. So it's a really
intense.
Yes,
intense
and
program.
we have our pediatrician, and she has her team, Dr. Richardson, that they make sure that all our HIV positive mothers, that the babies are followed up right up until we have their first ELISA test at 18 months. So and you know, everybody plays a very important role. And so, to me, it's about the success of our elimination is actually collaboration.
Yeah. Right.
You understand? Right. And I always say, I always appreciate also each pregnant woman that decides to have an HIV test, because they could have refused.
Of course.
You understand?
Yeah.
And then the program would not have been a success. Right. But instead, each one of them has stepped up to the plate and realized that it's important that I get an HIV test.
Yeah.
It's important that if I'm positive, that I
do follow up.
Yeah, I continue to.
So it's just everybody participating, doing their part. Noreen Jack is the Pan American Health Organization representative for Jamaica, Cayman Islands, and Bermuda. At the conference, she represented Bermuda and Cayman Islands, who were also certified. She says the ability to reduce the cost of medication in the Caribbean is a key factor to these islands seeing a dream become reality. She also made the point that mainly women, with the help of a few men, carried the dream to fruition. Please tell me about your role in helping to get the idea of elimination of mother-to-child transmission from seed to fruition.
Okay. It goes back some time, and I think it was really born from my experience seeing pregnant women who were HIV positive, treating them with antiretrovirals and taking care of their babies. But the date that I think we should look at in terms of the region, and when I say the region, the Caribbean, beginning with the Caribbean, is 2008. 2008 was the year we looked at the feasibility of whether or not we were able to be bold enough to speak about elimination of mother-to-child transmission. The science had progressed. The science, the knowledge of treating pregnant women with antiretroviral to prevent transmission to their babies, that was known. In addition to that, in the Caribbean, we were able to negotiate the reduction of prices. I remember the very first woman that I treated, her mother had to buy the medication based on a loan from a credit union. She just could not afford it otherwise. And at that time, before, you know, it was like 10,000 US dollars a year to treat one person. So that was really, and in terms of the equivalent of treating a woman on the shortened version of the treatment, that was like 1,000 US, really above the cost of their, you know, affordability of most people. So we were able to reduce the costs, and that, I think, the two alignment of the science and the knowledge that we had, as well as the reduction in costs, made it something key points that it was really something that could happen, that we can do, and we could afford to do, and that our programs in the Caribbean can adopt it, that the healthcare workers could provide the treatment. And it should also have been acceptable to the women. So in 2008, we had both from a scientific perspective, the feasibility based on the science, and as well as the discussion on the programmatic elements. And therefore, we began what we called the Elimination Initiative. At least it became known as Elimination Initiative. We had also at that time had discussions with other stakeholders. Of course, people living with HIV and their acceptance, whether or not it would be something acceptable. We also had with other stakeholders in terms of other physicians, policymakers, other partners beyond PAHO. Some of the key science, I will say scientists within in the Caribbean, as well as the pediatricians and obstetricians. They're all key people to participate in this program. And I think some may have been skeptical initially, but people saw that, yeah, we wanted to proceed, and we started. And We developed documents, we had planning, we supported capacity building of care providers in various countries. We helped countries develop their plans for implementation, and we identified various indicators as to what we would measure, like the coverage, how much women should be tested, the timing that they should have the tests, you know. And really what we built on was really the need for optimal antenatal care for all women. That's really what it built on, and continues. And now even, I think, we need to think of it progressing into family health. Good sexual and reproductive health, and overall prevention of HIV. So it had all those elements, but where we focused on initially was really the antiretrovirals, which of course made the difference in terms of interruption of transmission from mother to baby.
You were dealing with the larger countries of the Caribbean, so to speak.
Well, one of them, Jamaica, yes, and the other two are territories. Yeah.
Do you think that it is more difficult to get the population to buy into the concept of what you're doing in a larger population?
I think what has happened here is that we have started to validate the smaller countries, but the acceptance of the program, acceptance that I should have an HIV test when I'm pregnant, that is the norm, that if I'm positive I should be treated. I think that's acceptable to most Caribbean women. We have refusals. The availability of the services may be a little easier and smaller, but generally in Jamaica it's available. So in the most of the Caribbean countries you have access to the test and you have access to the antiretrovirals. So that's not the problem. I think what it is that why we're seeing the smaller ones moving forward first, they're smaller, so that you have for the validation process you have to show all your data and have everything available. And for the larger ones, it gets a little more difficult and takes a little more time to have that more ordered system. So if someone comes to review all your records, which they will do, I think it's taking a little longer. So it is my belief that all the other countries will move forward. The preparation may take a little longer in terms of, and when I say preparation, in the context of getting all the documents and so on, that yes, everything lined up, that will take maybe a little bit longer, but it will happen.
In this part one of the series, we talked with some of the practitioners who work directly with HIV-positive pregnant women and learned about the strategies and mechanisms they use. Tune in again for part 2 of the series, when we will talk with some of the leaders who supported these practitioners and made sure they had everything they needed for success. Until next time, thanks for watching CaribNation. I'm Derek Green.